Hi, I'm JP Lindsey. I'm an occupational therapist in Brooklyn, New York at the Brooklyn Hospital Center. I'm an adjunct professor at Long Island University. I attended University of Wisconsin-Milwaukee for occupational therapy school. So I'm an occupational therapist. I work primarily in inpatient. However, our hospital serves patients from pediatrics all the way to geriatrics, but most of our therapists are working with the geriatric population. So, but primarily, so anyone from 40 to over 100 in our community, and we treat patients in inpatient, outpatient, and an acute rehab, inpatient rehab facility. I myself have been working with the inpatient population for the past 5 years. We had a very, very small caseload that hadn't been worked with for a very long time. It started with, when I started, about 3 patients, and now I treat about 50, sorry, I have a caseload of about 50 per day. So it's very, very busy, but it's very, very exciting work. It's traditionally an underserved community. We're a safety net hospital, so it's about 50% of our patients are Medicare or Medicaid, so it's a very at-risk population. Well, after COVID, it seems kind of crazy to say after COVID now, after only a month, but so my caseload unfortunately dipped from that high caseload to about 20 patients, which is still enough and plenty to do. But fortunately, I have served on the ethics and critical care committees, so we were working hand in hand and very closely to try to prepare ourselves and anticipate the influx of patients. But the biggest changes have really been around the medical acuity of the patients. So normally our hospital will have a lot of patients coming from nursing homes and the homeless population, and then also, of course, other patients from the community. But as these patients have been coming in, we've seen a lot more patients coming into the ICU. We've had to expand our ICU beds from around 18 to over 30. Which then, of course, means that all of our step-down floors have had that same cascade as they've been, either trached or pegged or, needing oxygenation or higher levels of oxygenation. So it's definitely been a lot more challenging from that perspective. But it's been unique too, because we've had several of our staff that have moved into what we call the command center. And the command center is really a nice way of saying that we take phone calls and allocate different resources to different areas. So, we'll have somebody that says we need to get this filter into this room, and maybe we're out of filters. Where is one? But it's challenging in its own way to sit on the phone all day, but it's really rewarding to know that you're helping allocate resources to where they need to go. Well, so we see patients in all the stages. So we had a tent that was outside of our hospital that would be evaluating and kind of triaging those patients and then doing some of the testing. So most of those patients were ambulatory with very mild symptoms or just concerned citizens who wanted to see if they had it, if they needed to quarantine themselves further, all the way to very, very critically ill, intubated, sedated patients. Unfortunately, we don't have ECMO at our hospital as a community hospital. However, we're partnered with Mount Sinai and a couple other hospitals so that, if a patient requires that very high level of care, they do that. But with COVID, one of the ways that our job has really changed has been trying to cohort those patients in the hospital. So, a patient who might be a person under investigation might be somebody that we don't treat or evaluate just to avoid cross-contamination and spreading of the virus. So, we have, patients who would be COVID negative, we have patients who are COVID positive and persons under investigation. And so the hospital is working very hard to try to find a way to cohort them into different areas so that we can continue treating them. And I think it's going to be really interesting how hospital systems adapt and kind of overcome as this virus changes. changes the way that we think about hospitals and rehab centers, and I think an entire healthcare system, just to save the maximum number of lives, but to also maximize the level of treatment that we can give to them, because a lot of these patients are because a lot of healthcare staff are being limited in their ability to treat. So some hospitals I've read are having therapists who aren't treating the patients because they're not considered essential in the care of the patient. They might be reassigned. Whereas fortunately myself, the way that I want to treat, the way that I want to work is to be in the rooms with the patients. It's going to be really interesting to see where we fall, and as we develop these protocols and these treatments, from the top down, from administration to ICU beds to community involvement. How are we going to do elective surgeries moving forward if there's a concern for infection, and so it'll really drastically change the way that we're working as a hospital. So it'll be interesting, and I'm excited for that challenge, but it'll be tough. It'll be a lot of change in a very short amount of time, for sure. A lot of it, I think, the same as a lot of people, is that it was very ad hoc. It was a lot of as research was coming, from overseas, a lot of it clearly coming from Italy and Europe. We were kind of taking it, one day at a time with the new research. And then, unfortunately, it seems now that, we might have been having some of the first cases in New York City as early as January, but they were just being misdiagnosed or misidentified, not necessarily at our hospital, but, just across, in the community in general. But the really good thing is that we've been having daily huddles and daily communication from our our management staff, from all the way at the top to my immediate managers, who are communicating with us regularly about the number of patients, number of ventilators, and the types of things that we're doing as the CDC in New York State keeps changing recommendations and guidelines and things like that. Even up to is the subway closed today type things, which fortunately has not happened, but we're just trying to anticipate all of those different challenges, when you're in disaster mode, to figure out what needs to happen. So a lot of my work hasn't changed at all. I would be treating these patients in a lot of ways, the ways that I would treat a patient with chronic lung disease, COPD, or a patient who's waiting a lung transplant, or just a really severe case of pneumonia. I'm working with them and watching their respiratory status. I'm doing evaluations and treatments and early mobility, which most early mobility research has been around for over a decade, and so it's something that those patients need to be moved early. They need to be moved often. We need to be getting them up into chairs and walking and getting them down the hallway and whatever way we're allowed within the limits of our lines and tubes and drains and whatever else. So, it's a lot of that has stayed very, very similar. But as I was saying, with the different committees, it's been really interesting to try to bring some of those quality improvement things into the rooms as that research is coming out on a day-to-day, whether it's a new medication that a doctor is working with, or something that we're doing from a therapy perspective. But the really cool stuff is that the research, like I said, has been around for a decade. So even if they're intubated and sedated, just trying to work with those patients. And then the doctors themselves have been, I've heard from other hospitals, and I've also seen at my hospital, have been doing a lot of the work proning the patients, getting them onto their bellies, even if they're intubated and sedated, and trying to improve the pulmonary status in any way possible, or respiratory status, and seeing what can be done to keep them off of the ventilator as long as possible, and just improve those outcomes. So a lot of it, though, is really coming down to, if I'm trying to prioritize my day, like what am I doing differently compared to what I was before, and a lot of that is just trying to change, where normally I would just choose an evaluation and treatments and just follow up with those priorities that I have throughout my day. Now I'm having to triage on a totally different level, to say, here is my patient. who's an evaluation, but they're COVID negative. And here's my patient who's a COVID positive, and I need to triage and say, all right, I'm gonna see my COVID negatives first, and then I'm gonna see my COVID positives, and structure my whole day around that. And then if PPE is limited, which fortunately it hasn't been as limited as it was initially, but maybe I'm saying, so I'm going to see my COVID negatives over here, and then my COVID positives by floor, so that I can reuse certain pieces of PPE. And it's created its own challenge around how I'm prioritizing my and scheduling my day in a way that I've never ever had to do before. And it's just very, very difficult, but it can be done. It just takes an extra set of eyes sometimes to to think things through and decide where to go. Absolutely. So the main resources I would recommend would absolutely be some of those early research articles by Needham and Schweikert from 2009 and 2010 that really discuss the benefits of early mobility and how safe it is. So, in my hospital, when I originally started, a lot of the physicians knew that it was possible, but they didn't have the staff to really work on that. And that was one of those things that, as a quality improvement project, I was really focused on. So I really recommend that therapists get in on that research and find that training anywhere that they can. I remember years in the past where, going to AOTA, they had lecture after lecture of early mobility. So it's been around, and it's definitely beneficial. So just reading that, familiarizing yourself with that. Same with any of the proning research, which you can find multiple articles on. That's been around since about 2013. That kind of stuff can really make a dramatic improvement. At this time, one of the things that I would absolutely recommend is, if you don't know something, this is where you can reach across the aisle to somebody at another hospital and just call them and say, hey, at any of your local bigger hospitals where they might be doing work like this, and say, walk me through what I need to do. Or, if you have some of your staff that are being furloughed or spending time away, say, can I shadow you and find out how to bring this back to my hospital if you're spending some downtime? These are some ways that you can get some business time, scheduled in from your hospital, and might even be paid, where you can really get that experience and then bring it back to your hospital. And it's a tremendous opportunity to change a lot of lives. You're able to prevent, things like contractures that are otherwise preventable. You're able to mobilize patients and get them off of ventilators earlier, which decreases ICU stay, which decreases ICU days overall, and ventilator days, decreasing that, which of course ends up saving money for your hospital. So it's really a tremendous win-win to be able to do that, which, for those hospital systems that are really overburdened, decreasing somebody's hospital ICU stay by 5 minutes or a couple hours might mean the difference between life or death for another patient who might need a ventilator or some of that equipment. So it can really, really benefit the entire system, not just a single patient, which obviously we care about them a great deal, but it's just so absolutely necessary. So absolutely. So many of you are dealing with it now, but preparing yourself, your home and your family for it. It's not a typical disaster, right? This isn't a hurricane or tornado. This is something where we have the time to kind of plan and prepare. I've sent my own wife and dog away, and it's frustrating and it's challenging to be isolated by myself. But at the same time, I know that I'm still doing great work in the community, and I'm able to keep myself and my family safe. But this doesn't work for everyone. So just taking that time out to kind of plan and have those harder discussions now, if you haven't had them already. And then really just knowing that isolation is one of these very, very difficult things, not just for yourself. So finding your own way to be mentally prepared for that is obviously crucial. But then knowing that your patients are also having that to a degree that you still get to leave the hospital at the end of the day, and your patients are in a room by themselves with an annoyingly loud HEPA filter that keeps their room sometimes very hot, so they're uncomfortable and they're alone and they're isolated, and they're doing that all day. And when the hospital is deeming that your patient can only see essential personnel, it just means that even the normal day-to-day interaction, working with someone who's in the food like in the department serving you your food tray, and they're coming in and you get to know that person well. It just isn't the same way now, where they drop it off on the table and they don't talk to you because they can't, or they're not supposed to. It just changes really the dynamic of kind of quality of your hospital experience. And knowing that they are isolated just means that therapy interaction means that much more. Those extra couple minutes of just talking to the patient about anything is really crucial for them. And I've seen it work wonders. Even just, therapeutically, just the therapeutic use of self makes a really huge difference. And then, really some of the last things is that, we're some of the biggest experts in what we do. So advocating for yourself comes first and foremost, saying, hey, I want to go get training at another hospital to bring this back here. Or, hey, I know that I can put a patient prone. I do it all day, when I'm turning and I'm cleaning my patients. These are things that we do all of the time. And so we have so many different skill sets, like I said, I'm part of this ethics and critical care committee. We have knowledge in so many different areas that apply to multiple areas of hospital systems and healthcare systems. And we can provide feedback for them in ways that keep us relevant instead of being furloughed, or taken out, and spending, half days or something like that at work. We want to, when we're one of the biggest and most employed professions in the country, there's no reason when we're having one of the biggest healthcare crises that we're not at work and being utilized to the fullest extent. And so that means just continue advocating for your patients as well. And that's, just when they're alone and we know the best outcomes and we see it day to day, we just have to keep advocating day after day after day. And we know that those communities that are already at risk are poorer communities, are homeless populations, and the elderly. When we know that they're the most at risk for these types of things, we have to say that even though the regulations in the hospital things are guidelines are changing on a day-to-day basis, it doesn't mean that someone who wasn't safe to go home last week is suddenly safe to go home. We have to keep advocating for them and try to make sure that whatever we can do for them, we can do. And obviously it changes, and you might get into disagreements. You just have to take it in stride and say, tomorrow's another day. Like, we're going to be okay, and we're going to overcome this. And we just have to convince other people that what we're doing is important and it matters to these patients. So we'll be okay. It's just going to be very different, but we'll be all right.